Hi, everybody. Welcome to the Violence Prevention Center poster session for the inaugural U of M Injury Prevention Center Research Symposium. I'm Mark Zimmerman, and I'll be moderating this session. Thanks for joining us. I'm going to just give you a few ground rules. We're recording this session. I just want everybody to know that. And only our moderators and presenters, only I and the presenters will be visible. Chat will be disabled, so if you have any questions you'd like to ask at the end of the session, you have to use the Q&A feature. And then what we decided to do is have all of our presenters present first, and then you can ask we'll have a Q&A period after that. And if you have a question as they're going along, however, just type it into the Q&A and we can work it in later. Our presenters will have 4 minutes to present their poster. We will share their poster slide while they're speaking, but you can also access their posters at Injury Center, all one word, .umich.edu /research-symposium-2020. And those will all be available again if you go to our website when we're all finished with our symposium. There'll be 5 other symposium sessions going on right now. And while we encourage you to stay with us, if you see another poster that you'd like to see, feel free to bounce in between them, come back here and whatnot. I'm going to read the list of the presenters, so you'll know the timing of when they'll be on if you want to come back later for somebody that you're hoping to hear them speak. We have Jennifer Conley from the University of Michigan, Siravan Sang from the Department of Surgery here. Not here, at the Grocers Keystone Health System in Upland, PA. Vijay Singh is here of the University of Michigan Medical School and a member of our Injury Prevention Center. Dr. Lisa Fedina from the University of Michigan School of Social Work. We have Nicole Brass, a doctoral student who just defended her prospectus. She is a doctoral student in our combined program in education and psychology. Ellie Thompson from my department, Health Behavioral Health Education in the School of Public Health. Yvonne Lee and Ryan Rogers at Oakland University, William Beaumont School of Medicine. We have Asta Patel from the University of Michigan Injury Prevention Research Center. And then lastly, Jessica Roche, the University of Michigan Injury Prevention Center, and who's really been behind the organization of this whole symposium. So we especially thank her. So let's begin. Jennifer, you're up.
All right, so my name is Jennifer Conley, and I'm with the University of Michigan's Injury Prevention Center. I will be speaking with you today about the Project Interact study regarding feasibility and acceptability of a smartphone app to assess daily substance use and firearm behaviors among an urban ED sample. So in regards to background, we know that firearm violence tends to be a leading cause of death among youth in the US. We find that emergency departments tend to be a key location to implement injury prevention efforts as youth intersect with the medical system at a potentially teachable moment of intervention. We describe the feasibility and acceptability of the use of a smartphone app to collect daily data among a high-risk youth sample recruited from the ED. So in regards to the methods used, research assistants systematically approached all youth between the ages of 16 and 24 that were seeking ED care regardless of presenting complaint. So following the consent, youth completed a computerized screening survey on an iPad. Those who screened positive for substance misuse and firearm possession were enrolled in a 30-day longitudinal daily data trial. 31 items were collected daily for 30 days, and a 3-month follow-up was completed. Daily assessments included adapted validated instruments measuring the participants' prior day substance use, fighting, firearm behaviors, as well as current mood, cravings, impulsivity, sensation seeking, and stress. Participants were also asked about prior day activities, such as where do they spend the most time during the day, and the perceived safety of those locations. Follow-up surveys asked about feasibility, usability, and acceptability of a smartphone app to collect daily data on sensitive subjects, including substance use and firearm behaviors. So in regards to feasibility, roughly 1,300 youth between the ages of 16 and 24 that were seeking ED treatment for any reason were screened during their ED care. 66 youth screened positive for substance misuse and firearm possession. Out of the youth that screened positive, 60 youth completed the baseline survey and were eligible for enrolling in the daily data trial. 88% of eligible participants enrolled in the feasibility trial, with 82% completing the 3-month follow-up survey. The socio-demographic factors of those enrolled in the daily data trial are that 43% of participants were male, 67% were African American, and 57% reported receipt of public assistance. The mean age for participants was 24 years old. In regards to usability, 92% of participants reported the app was easy to use, 84% reported that the daily surveys took less than 10 minutes to complete, and 40% reported morning windows were the most optimal time for survey administration. Some of the barriers, rather, to survey completion included lack of time or simply forgetting to complete the survey. For acceptability, 92% reported that they were very or somewhat comfortable answering questions about substance use, violence, and firearm questions on a smartphone app. 80% reported the capability of keeping their survey answers private, and 82% reported that they would be willing to enroll in another daily data collecting similar information. I would also like to note that none of the participants reported any police or legal issues resulting from their study involvement. So in conclusion, future studies should examine promising mechanisms for increasing rates of compliance, including price-based contingency management strategies. Findings have implications for the development of interventions addressing substance use and high-risk firearm behavior, and suggest that assessment and delivery of tailored content may be a promising approach to addressing these behaviors. Thank you for your time.
Good morning, I'm Sarah Von Sang. I'm a general surgery resident at Chester Medical Center in Southeast Pennsylvania. And today I'll be presenting our research on the current burden of firearm injuries in our region. So firearm injury, as you know, is a major public health concern in the United States. In our actual institution, it's located in a city that actually has a homicide rate that's 92 people per 100,000 of population. And that was in 2018. And that's a stark contrast compared to the actual overall rate of homicide for the US, which is 4.9 out of 100,000. So what we did, we looked at our PTOS study database, which is actually the Pennsylvania Trauma Outcomes Study database that includes all the trauma centers in Pennsylvania and its mandatory reporting. And we did a trend of actually from 2009 to 2019, looking at all of the patients who had come into our institution that had suffered penetrating gunshot injuries. And what we saw, and not really too much of a surprise to us, is that the majority of our patients were African American. They were 84.3%. The majority were male at 90.2%. And the large number of them were in between the age ranges of 20 to 31 with a median age of 24. So young African American and men were the majority of our patient population. And our overall median injury severity score was 9, which is actually lower than I had anticipated when initially starting out this study. We did do a sub-analysis of these patients, and when we compared the patients who had mild to moderate injuries and those who had severe injuries, and we had delineated those by an ISS score of 16. Those who had severe injuries, of course, had higher rates of MTP activation. They had longer ICU stays, longer hospital length of stays, and a higher rate of in-hospital mortality at 6.3%. We also took a look at the overall in-hospital mortality rate, and that was 8.2%. So we trended it over the 11 years, and it had actually decreased, interestingly enough. And in the middle of the poster, you can see the actual incidence per year had gone up for firearm injury. However, the mortality rate went down. And that could be because our advances in ATLS, how we resuscitate patients, and how we care for them later on as medicine has advanced over the past decade. We actually did a heat map and saw that the majority of our traumas that we had received from our encatchment area were located in Chester City, which is the city that we are adjacent to. We're located in Upland, Pennsylvania. So in conclusion, really, because this was a retrospective study, of course, we're limited to what we have in the database. So we really weren't able to survey patients. And that's really our next step in going forward with prevention. So we're establishing a hospital-based violence intervention program now, and seeking research grants in order to provide funding for violence intervention coordinators. And that's it for my presentation. So thank you for your time.
Yeah, hello. My name is Vijay Singh. I'm a family medicine physician here at UVM and part of our injury prevention center here at University of Michigan. I'll be talking about a project where we looked at intimate partner violence, looking at physical violence, intimate partner violence, and then looking at men, perpetration and victimization. So acts of violence that were committed by men or acts of violence that men received or were victims for. So there are a few national studies that look at the prevalence of violence, partner violence committed by men, received by men, so perpetration, victimization. And a few of those studies look at partner violence in categories. Like there's many that look at just perpetration or just victimization. We were looking at the overlap of the two behaviors. As we might know, there's situations of mutual violence where there's both perpetration and victimization in relationships. So the purpose of our study was to assess physical, intimate partner violence, perpetration categories, victimization categories among men, and look at correlates for those behaviors. We used a nationally represented sample of men. It was about 1,000 men, young men between 18 and 35. Younger men have higher rates of violence than do older men. We did this study back in 2014. We looked at various measures, demographics, age, race, the children, the presence of children in the home, beliefs about children, smartphone use, health services use, as well as self-reported physical health diagnoses and mental health or substance use diagnoses. We conducted survey-weighted descriptive statistics to look at prevalence, and then we also conducted a multinomial logistic regression where we could compare these categories of perpetration only, both perpetration and victimization, or victimization only, and comparing it to a reference group of no violence. And of note, for the violence measure, we adapted what's measures from the conflict tactic scale, looking at physical acts like hitting, slapping, punching, and beating. So for prevalence, then this was essentially lifetime figures rather than just past year. Perpetration only was a small amount, 2.5%, so about 1 in 40 of our nationally represented sample of young men. Both perpetration and victimization was 16%. That's about 1 in 6. And then victimization only was about 10%, so about 1 in 10 men reporting that. I'll just draw attention to the both group, the 16%. Out of all men who disclosed violence, that was over half. So most men, if they disclose violence, was this kind of mutual violence category. And then just looking at the data that we didn't subsequently analyze, any perpetration was about 1 in 5 men. Any victimization was a little over 1 in 4 men from this group. So looking at our kind of descriptive statistics, average age was 26. Almost 40, well, a little over 40% were not white, so of another race. And about half had a regular doctor for care. In the sample total, a number, about 1 in 4 had mental health care visits. And then various reporting for physical health, mental health diagnoses. To draw our attention to the multinomial regression, so the factors that were significant included children as protective factors for both perpetration and victimization. Maybe we can explore that a bit more in the Q&A if we want. Having health services was a protective factor, chronic pain or mental health substance use disorders where there was higher risk. So the significance, I think, with health services use suggests that men who perpetrate or are victims of violence seek care, and in those settings, we can ask about perpetration of violence or associated factors. Thank you.
Hi, everybody. My name is Lisa Fedina. I'm an assistant professor in the School of Social Work and presenting on a study that myself and my colleague, Dr. Sarah Peitzmeyer, my co-investigator in the School of Nursing, on a study that we did exploring intimate partner violence and economic insecurity during the COVID-19 crisis. So we know that Americans right now are facing extensive levels of economic insecurity during the COVID-19 crisis, particularly as it relates to meeting basic needs for food, for healthcare, and other household expenses. Recent surveys have found that 1 in 7 households with children have lacked sufficient food. 1 in 6 housing renters have been behind on their rent payments. And that Black and African American, Latinx, Native American, and immigrant communities are facing especially higher rates of food and housing insecurity, as well as other financial hardships during the pandemic. Along with rising economic insecurity, media reports and emerging survey studies have documented a global trend in elevated rates of intimate partner violence among women during the COVID-19 pandemic. And it's very well documented that IPV IPV exposure and victimization creates extensive financial and economic burdens for victims. And because of this, survivors of IPV might face even greater economic vulnerabilities during the COVID-19 crisis. So in this study, we explored the socio-demographic correlates of 5 forms of economic insecurity induced by the COVID-19 pandemic. And these include insecurities in food and nutrition, in housing, in phone and internet services, in medical care, and just access to disposable income. So using Qualtrics panels, we recruited a census match sample of 1,169 cisgender women and transgender non-binary adults who were English speaking and over the age of 18 living in the state of Michigan. So we administered this cross-sectional survey online between June 26th and August 11th, although the majority of the data were collected in the first week of that time period. We used self-reported, validated, behaviorally based measures of physical, sexual, psychological, and technology-based IPV, which were combined into a composite variable. For the economic insecurity variables, participants were asked to indicate whether their access and affordability to food, to housing, phone and internet, medical care, and income had decreased since the start of COVID-19. We found that middle-aged women and trans non-binary participants ages 18 to 34 reported significantly higher rates of all forms of economic insecurity compared to other age groups. Similarly, multiracial participants, sexual minority and queer participants, and trans participants reported higher rates of most forms of economic insecurity than their counterparts. But we didn't find any significant differences based on socioeconomic status, with one exception, and that was housing, where participants with lower incomes and education levels reported higher rates of housing insecurity. In the adjusted regression models, IPV victims had over twice the odds of experiencing phone and internet insecurity and healthcare insecurity, and over 3 times the odds of experiencing housing insecurity since the start of the pandemic compared to those without IPV exposures. So we conclude that routine screening is essential in healthcare settings for both IPV exposure, as well as specific forms of economic insecurity, particularly housing during the COVID-19 crisis. And that policy aimed at providing economic relief, and that policies related to eviction, rent, and housing affordability should consider the unique risks that IPV victims are facing. And these policies may prevent the disparities in economic insecurity faced by IPV victims. Finally, services and resources that seek to enhance phone and internet access, as well as expanded outreach efforts for medical care, can mitigate the disproportionate economic impact of COVID-19 on IPV victims and lessen economic vulnerabilities that might place some people, particularly women of color, trans individuals, queer women, and younger women at greater risk for experiencing IPV in the future. Thank you.
Hi, everyone. I'm excited to share some work that I conducted with my advisors in the combined program in education and psychology, as well as the School of Public Health here at the University of Michigan. So we know that feeling safe at school is obviously an essential need that must be met in order for students to thrive both academically and socially at school. Although school safety has been studied quite extensively, the present study is novel in a few main ways. The first is that rather than a general or global sense of school safety, we examined how safe students felt across various building locations in their school. We also examined whether these perceptions differed by several demographic characteristics, namely students' grade levels, socioeconomic status, gender, and race. And finally, we also examined whether perceptions of safety predicted greater worry and whether teacher and peer support could function as a protective factor to help students feel safer in school. So to address these questions, we conducted a survey. It was part of a larger research practice partnership on school climate. All of the students were part of schools from a large county school district in a rural lower middle class area. Over 1,000 students in 5th through 8th grades participated. The majority were white and nearly half qualified for free or reduced price lunch. On the survey, students indicated how often they felt safe in 4 locations: in their school, in their classrooms, in the hallways and bathrooms, and in the lunchroom and cafeteria. We also measured students' perceptions of teacher and peer support, which essentially captured how much students felt that they were cared about and could rely upon these entities for help. And we used social worry as a proxy for students' anxiety. So for findings, I'd first like to direct your attention to the top graph in the center panel of my poster, which indicates the percentage of students, how often they felt safe in the following areas. So in red, we have students who said never or sometimes. In orange is half the time, and blue is most of the time or always. So as you can see, students reported that they felt most safe in their classrooms, followed by in the lunchroom and cafeteria, generally at school, and least safe in the hallways and bathrooms. And you'll note that over a quarter of participants reported that they never or only sometimes felt safe in these areas. In regard to demographic differences, we did not find any differences by socioeconomic status or race, perhaps reflecting the homogeneity of the sample. However, we did find that across locations, boys reported feeling less safe than girls, and 8th graders reported feeling less safe than 5th graders. With regard to the role of teacher and peer support and the effect on social worry, I'll first start with the risk. So when students felt less safe at school, they did report a greater feeling of social worry. However, we also found that after controlling for demographic characteristics, both teacher and peer support led to enhanced feelings of school safety. We also found a significant interaction, suggesting that when students feel supported by both their teachers and peers, they have an even greater perception of safety. And so taken together, all of these findings can really help us begin the conversation on where we can start to help enhance student school safety. The first is that clearly location does matter, and so it'll be important to think about how we can prevent threat across these various locations. And we also may need to think about secondary intervention to help students respond to stressors and prevent social worry. And it will also be important to consider how we might address specific groups and their needs. So why is it that boys are feeling less safe and that older students are feeling less safe? It might reflect greater trends of physical intimidation and victimization. And finally, given the promising effects of teacher and peer support, what might we be able to do to help each other feel safer and more supported and welcome at school? Thank you.
Hi everyone, I'm Allie Thompson. I'm a first year MPH student in the Department of Health Behavior and Health Education. This presentation is going to go over a scoping review aimed at exploring what previously published literature is out there regarding sexual violence perpetration and sexuality education. Sexuality education, commonly known by its abbreviation, sex ed, is the teaching of human sexuality. I will be using the term sexuality education from here on out because the terms sex ed or sex education fail to recognize the components of sexuality education not directly involved with the act of sex. We used 3 different databases, SynHall, PsycInfo, and PubMed, to search for articles using the search terms listed under methods. We excluded any articles that were not conducted in the US because sexuality education practices and policies vary greatly country to country. We also excluded any studies not in English and those regarding special populations. We ended up with 11 studies. When we reviewed those studies, 4 major themes appeared. The majority of the articles were about sexual violence prevention programs that addressed resource availability, intervention strategies, and harmful beliefs about gender and sexuality. The interventions in this category focused solely on either bystander intervention or sexual assertiveness on behalf of individuals at risk of sexual violence victimization. In the next major theme, there were a few articles that mentioned the intersection of sexuality education, and sexual violence. They acknowledged the potential link between sexuality education and society's beliefs surrounding sexual violence and sexual health. The last 2 major themes were about sexuality education and treatment for survivors and perpetrators. All articles in those 2 categories focused on sexuality education as a secondary prevention strategy. The programs utilizing sexuality education as a treatment are focused on breaking the survivor-perpetrator cycle that is commonly seen in situations of sexual violence. Overall, as you can see from the timeline, there is a lack of rigorous research on sexuality education and sexual violence perpetration. With the majority of these articles consisting of literature reviews and cross-sectional studies, there is still a need for more extensive study. In summary, while there are a few studies that utilized certain components of comprehensive sexuality education, there is still a lot of untapped potential for comprehensive sexuality education to serve as a primary prevention strategy. Much of the focus on preventing sexual violence puts the onus on individuals determined to be at risk to take action to prevent the violence. It places the responsibility of sexual violence prevention on the shoulders of potential survivors to be vigilant instead of focusing on strategies that prevent the occurrence of sexual violence in the first place. If we can transfer the focus of sexuality education as a secondary prevention, meaning after the violence has already occurred, to a primary prevention, meaning before the violence has occurred, we could potentially alleviate some of that responsibility and focus more on reducing the number of sexual violence perpetrators from the start. Thank you.
Hi, everyone. Our names are Yvonne and Ryan, and we're 4th and 3rd year medical students at OUWD. We help to coordinate Classroom Connection, which is a health education and mentorship program at a local middle school. This year, we created an interactive weapon safety and cyberbullying lesson for our students. For some background, an astounding 87 children are injured or killed by guns every day in the US, and those involved in bullying are more likely to engage in suicide-related behavior, which includes the improper use of weapons. Our partner school district in particular has referred a disproportionately high number of students to the county's courts, which subsequently led them to be referred to youth detention centers.
So the overall goal of our program is to provide longitudinal mentorship to middle school students to better promote their personal health, their mental health, their academic success, and their future career goals. So really for this lesson in specific, we wanted to focus on weapons safety and cyberbullying. And we wanted to first kind of promote like what the prevalence was of these issues to the kids, and also to equip them with the resources and tools to better approach these situations going forward should they come up.
And for our methods, our program is based at a diverse magnet school in an underserved school district. We do pen pal exchanges and monthly in-person teaching sessions led by medical students. We cover topics ranging from health career exploration to physical and mental health. And for our weapon safety and cyberbullying lesson, we utilize an interactive online quiz platform. It's called Kahoot, and it allows participants to input like real-time answers directly from the devices. We also administered pre and post tests to gauge the effectiveness of the lesson, and we broke into small groups to facilitate in-depth conversation on their knowledge and their experiences with weapon safety and cyberbullying. You can see that here in figures 2 and 5, where they're sort of grouped up in small little circles. And one idea that really stood out to us was that they brought up the importance of checking in with a bully, because that they felt that bullies are often going through life events that cause the behavior in the first place. And lastly, we help them identify 2 adults to contact in unsafe situations. And they also create a class pledge to prevent bullying at school, at home, and as bystanders.
So on top of those reflections that we heard from the students and their motivation in this lesson, which was really great for us, we do have some of our result data here from the Kahoot survey that Yvonne mentioned. So first, I'll just direct everyone to table 1 on the left here. And those first couple rows kind of just showed that there was a decent amount of variability in how prevalent the students thought these issues were. And we also wanted to point out the very bottom row of table 1, where we saw that 84% of our students have experienced cyberbullying in some aspect. So we thought that was a pretty striking number. So then after we did our small group discussions, our large group discussions, and the kids presented, then we had another post test, and we have this in table 2 on the right. And we wanted to point out that on the bottom row here again, over 80% of the kids all thought that compared to before the lesson, that they knew much more about cyberbullying and about weapons safety. So we were excited to see those numbers.
In conclusion, we feel that health education and mentorship programs like Classroom Connection are really necessary, and they can aid in the prevention of significant health risks for adolescents.
Yeah, and really the reason we wanted to talk to you guys about Classroom Connection is we think that our program offers a pretty innovative and solid foundation and framework for schools to involve other community members, other universities, just to better promote the learning, the health, and the future progression of their adolescent students. So thank you all for listening, and big thanks to our team as well for helping us put this together and do these lessons.
Thank you.
Hi, everyone. So I will be presenting a poster titled Correlates of Violence Among Adolescents Receiving Health Interventions. And so a little bit of background on why this work is needed is that alcohol and violence are linked with injury and mortality among youth, making emergency departments advantageous for interventions to alter risk trajectories. So the foundation of the study is really to find scalable and cost-effective interventions that can happen in a hospital setting that aims for reducing risky behavior among adolescents. So previous research done by the principal investigators in the study have found that a brief intervention titled Safer Teens has been effective in reducing those interventions. This study sort of builds on it by adding booster interventions that could be so there's two different interventions that have been created: text messaging group and a health coach group. And so these are some of the booster interventions that are aiming to further the engagement and help in assisting reduction in those risky behaviors. It's important to point out, so that this is preliminary data. This study is still recruiting, and so this is a longitudinal study, and we're really just looking at the first cross section of the study. So we recruit 14 to 20-year-olds in the emergency department that have endorsed binge drinking and aggression within the past 4 months. And so below is the kind of the outline. So the first day they do the brief intervention, and then the weeks 1 through 8 is when they would have those booster interventions. So sort of looking into the sample that we found is that the average age is around 18 years old. Majority of the participants are female. And in parallel to where we're recruiting, which is Flint, Michigan, there's high rates of poverty in African-American families. And so majority of the race is African-American, and 52% receive public assistance. When we're looking at sort of the risk factors, there's high rates of severe aggression, 8.6 drinks average over a weekly consumption for alcohol, high rates of marijuana use, and then positive screenings for depression and anxiety. So, a variety of different risk factors that these, youth members are really facing here. So when we're looking at correlations of some of these variables to aggression, what we're finding is that men are often more associated with aggression, impulsivity, so not thinking about before doing something is also correlated with aggression. Peer drug and alcohol use, how often you're using marijuana, alcohol consumption, are all correlating with aggression. And lastly, community violence. So we measure that by asking questions like, are you hearing gunshots in your neighborhood? Has your house been broken into? I saw someone get killed or shot or something like that. So those are some of the ways we're measuring community violence, and that is also highly correlated with aggression. So when we include all of these variables in a regression simultaneously, what we're finding is that the 3 most robust variables that are associated with aggression is impulsivity, alcohol severity, and community violence. And so these findings are really telling, and also further really focusing on these risk factors is that there is a need for violence interventions to address individual factors, particularly impulsivity and alcohol consumption. And the goal is to build resiliency and give PTs tools and skills to cope with some of the circumstances that they might be facing. So I'm happy to answer any questions in the Q&A, and thank you so much.
Hi, everyone. Thank you for attending today's session. My name is Jessica Roach, and I am the Managing Director here at the University of Michigan Injury Prevention Center. Youth violence is a critical public health problem, and although youth violence is the leading cause of death and has major impacts on the health and well-being of young people, it can be prevented through evidence-based interventions. One such intervention, the Safer Teens Brief Behavioral Intervention, is delivered to youth by a therapist in the emergency department in a single session intervention. In 2006, Safer Teens, a randomized controlled trial, was implemented at the Level 1 Trauma Center, Hurley Medical Center in Flint, Michigan. Youth aged 14 to 18 seeking care in the emergency department and reporting past year of violent aggression and alcohol use were eligible for the study. This brief 30-minute one-on-one intervention that's delivered in patient care spaces aimed to reduce and prevent violence and alcohol use among urban youth. This intervention incorporated motivational interviewing techniques to empower youth to change behavior in a respectful, non-confrontational, and non-judgmental manner. The intervention includes tailored feedback for alcohol use, violence, and weapon carriage, as well as decisional balance exercises and role plays. Overall, findings from the randomized control trial found that at 12 months post-intervention, participants showed significant reductions in the prevalence of their peer aggression and peer victimization. A cost analysis was also done of implementing this program and found that it would cost $17.06 per event averted to deliver the intervention, less than the cost of an IV. There is a tremendous need within public health to accelerate the transfer of such evidence-based interventions into routine clinical care. And so this presentation details this work in primary care clinics. This pilot implementation trial was completed in 3 phases. In phase 1, we obtained feedback from stakeholders to inform the implementation packaging of the Safer Teens program for primary care. In phase 2,
we implemented this customized Safer Teens PC or primary care program and conducted a quasi-experimental pilot study involving adolescents aged 14 to 18 who screened positive for recent aggression. Participants were assigned to a usual care control condition or an intervention condition receiving the Safer Teens PC program, and all youth received a 3-month follow-up. In phase 3, we conducted stakeholder interviews to examine barriers to maintenance. Based on stakeholder interviews, we created a web-based Safer Teens PC package, which includes a violence screener, intervention delivery tool, training videos, and text message boosters. During phase 2, 49 participants were recruited to the control condition and 61 in the intervention condition. The 3-month follow-up rate was 91.8%. Interventions were delivered by clinical staff, with one of the clinics delivering the intervention 100% through telemedicine, through telehealth, and the other clinic delivering the intervention either in person with youth or through telehealth. Using an intent to treat approach, the intervention group showed significantly greater reductions in severe peer aggression, anxiety, and substance use consequences relative to the comparison group. Other outcomes were in the expected direction, with greater reductions in intervention versus comparison group in peer victimization, substance use, intention to avoid fighting, and depression. These findings speak to the untapped potential of clinical settings, such as primary care clinics and the emergency department, for reaching at-risk youth who may not otherwise receive patient-centered violence and substance use interventions, like the Safer Teens program. Our findings suggest that the Safer Teens PC program could be efficacious and acceptable both to patients and clinical staff. But in order for violence prevention programs like Safer Teens PC to be more widely implemented, there is a need for clinical practice to catch up with the science. Specifically, during initial conversations with clinical administrators at our 2 implementation sites, the lack of reimbursement codes for violence interventions, as well as the telehealth component of our intervention, were raised as potential threats to the long-term feasibility of offering the Safer Teens PC program as part of the clinic's usual care. Given the advances in billing following the enhanced capacity of healthcare providers to offer telehealth visits in the wake of COVID-19, future directions for this work include exploring new reimbursement options to identify sustainable mechanisms for supporting the larger scale implementation of the Safer Teens program. If these challenges could be addressed, provision of violence prevention in primary care could have a high impact on health outcomes of adolescents. Thank you so much for your time today.
Well, that was pretty interesting. At least I thought so. I hope you all did too. Jessica, you're gonna put up that slide with the where to go for the recordings later. And all the presenters, please come back on camera because we'd like to do question and answers right now. But I want to just point out to you. Well, you jumped too fast.
1 second, it's on the very first slide.
Oh, okay. Just very quickly, I wanted people to see on the bottom there, the injurycenter.umich.edu Research Symposium 2020. That's where you can go and see the recordings, anything you missed, anything you want to hear again, and also looking at the posters more carefully on your own time. So with that, I'm going to start off the question and answers. And if anybody has a question and answer who's listening, please just type it in the Q&A down on the bottom of your screen, and we'll get to those. My first question is for you, Lisa. So warm you up. So okay, there you go. You wake you up, get you going. But really, what I wanted to know is what's thinking about the elevated risk for experiencing healthcare insecurity during COVID-19. When you live in the time of COVID, right? How might healthcare providers assess healthcare needs and expand access to those most in need?
Yeah, absolutely. That's thanks, Mark, for that question. It's a great question. I think, as you know, our findings suggest in this era of telehealth, that we might consider making telehealth more accessible to folks who are lower income, of lower socioeconomic status. Also, but considering the whether or not potential patients have access to internet. or no computers at home. So expanding access around telehealth might be a consideration, but knowing that people might not have regular, consistent access to internet, in-person visits, remaining open to in-person visits, even for non-urgent concerns, for folks who can't do telehealth, can still come in safely, given that medical providers are often one of the first sources of disclosure for survivors. And so if we get rid of medical visit options for some groups of women, this really closes their options. So, so that's something really important to consider. And then also the US Preventative Services Task Force does recommend routine screening for IPV for any women of childbearing age. So we recommend doing that and also extending that routine screening to trans and non-binary folks as well, and really consider potential screening options to around housing and food insecurity to link patients to social workers to get access to those needed supports.
Great, thank you. Next question actually came in for Vijay. Vijay, tell us more about your perspectives on about the child variables. How might children, why would they be protective for the odds of being a victim of IPV?
Yeah, thanks for the question. I mean, we've probably all heard, and there's another session going about adverse childhood experiences. So it's the idea that, if people witness violence amongst their parents, that is an adverse childhood event that is linked with future health problems. It can also be kind of a motivational tool for men if they have children, knowing that maybe if they had witnessed violence and the adverse effect it had on them, it could be protective as thinking about what effect does this have on my children. We had asked actually a question rather than, is your child witnessing violence in the home? Do you believe that if a child has violence in the home, this could be an adverse event or harmful? And we found that men who agreed with that statement, that had that belief, had lower odds of perpetrating violence against a partner. So we think that in eventual interventions, focusing with perpetrators of violence on that idea of a child if they have it, or remembering possibly their own experiences of witnessing violence, it could be a point that could change behavior.
Right, thank you. Jen, the next questions, they're sort of tied together, so I'm going to just put them right out there to you. What have been some of the barriers about implementing Project Interact? And then relating to that is, how have you addressed some of the intense topics that participants obviously would bring up, and how did you handle that? So there's sort of both kind of implementation kinds of questions. If you could just let us know what you think about that.
Well, thank you for the question. So I would say in terms of barriers, what we found were that a lot of participants just kind of had a lack of time or just simply forgot to complete the survey. The majority of participants were enrolled in school, in addition to some of them working. So they were just, definitely trying to identify the proper time during the day that they can get it completed. We also had like a dashboard that we could assess, so we could definitely see the survey compliance for the participants. And with that being, said, we definitely would send out like encouraging text messages to them, just encouraging them to, definitely take the time to complete it. So, and then in terms of like with the topics, I think for the most part, really being transparent with the participants in regards to what we were looking for. And with that being said, I think they were definitely, happy to see that someone was reaching out to them to learn more about some of their behaviors and, some of the things that they have going on in their lives, and knowing that they can make a difference by providing, just some of what their experiences have been, and knowing that it could not only help them, but also help other youth in the future.
Great, thank you so much. So Yvonne, there's a question for you about some of the data you showed, sort of downtrending mortality rates, but increasing rates of firearm violence. So what are your thoughts about that? Are we just better at keeping people alive once they're hurt by a firearm, or what?
So I definitely think that's a great question. That was something that we had noticed. So a couple of things that we think had happened over the years. There was Stop the Bleed program. People have had better access to large, widespread training to actually get patients to the hospital. Our EMS providers have been better at their transport time. So now instead of attempting to resuscitate them in the field, they scoop them and then pick them up. The transport time is minutes. Our ED physicians, our trauma physicians have been getting better time after time, again, with responding to these traumas, making sure that we have adequate equipment. There is the development of the Roboa, which is an endovascular balloon that can also stop essentially arterial flow from the thoracic aorta and down, that can help patients at least stabilize them to go to the operating room. So I think that the advancements over the past couple of years have been, phenomenal. So even though the incidence of firearm injury and the access to firearm injury is becoming easier, and thus resulting in a higher penetrating rate each year, we are getting better at addressing those things.
One of the implications, I think, for that, for research purposes, would be not to necessarily look at mortality rates, to really try to understand firearm violence in general. Obviously, if you're interested in fatality, that would be one thing, but it may not be the best indicator of rates or of what's happening out there in the field. And I guess that's good news, right? I mean, it is good news. It's bad news that it has to be implemented, but good news that we are getting better at that. Another question came in for Nicole. You ready? Okay. You get called on. It's kind of like you're in class and you get called on, and okay, I better pay attention now.
Yes, that's exactly how I feel.
I just give everybody, a heads up. So, what do you think your findings in terms of the space in schools, and Ron Astor's work about space in schools, just what does it mean for basically school officials and teachers and basically school policy? What role can they play thinking about space, the spaces in schools? What role can they play in helping kids feel and be safer in schools?
Yeah, so I mean, our findings were essentially that students are feeling less safe in areas that generally have less supervision. So hallways and bathrooms and things like that. I think that we need, so perhaps like figuring out like what exactly those threats are. I'm hesitant to say like without evidence that, increased supervision and like kind of more policing of those areas would be helpful. I think that we would need to really understand those things more before that came into play. But I think it's really encouraging that having a more positive school climate and when students feel like their teachers and their peers care about them. So I think that a couple of different things. One is kind of thinking about, preventing the threat and figuring out what's going on there, but then also increasing students' like feelings about school climate, that they belong at school. That will also help. So I think policy can kind of do both of those things, preventing the threat and also trying to help student morale.
Great, thanks. It always think about, obviously the bathrooms are always a dangerous place, right? But it's kind of weird about how do you monitor that?
Yeah, a few of the schools actually like removed the doors from the bathroom, not like from the stall, but like just to enter the room, they removed the doors. I'd say we don't really know yet if that's an effective practice or if students, appreciate that. They probably don't. So yeah, definitely still more to think about there.
Yeah, then another, thinking about what Lisa's work is thinking about, trying to maybe make single person bathrooms instead of the gang bathrooms that are in many schools. And, that also helps address the non-binary identifications. And so there, it might be a benefit for thinking about those, that kind of context as well. Of course, that's, sometimes expensive. Anyway, sorry for the editorialization. I'm just the moderator here. Yvonne and Ryan, I have a question for you, and it kind of plays right along with the question about schools and the Classroom Connection program being affected by COVID-19. How does that work for you guys? How does that play itself out, in this time? I mean, obviously it'll be different, hopefully soon, certainly hopefully within my lifetime, but in the meantime.
Yes, thank you for the question. So our school did switch over to virtual teaching when COVID started. And because the adolescents are home so much more, like near weapons and on devices where cyberbullying can occur, we feel that our lessons are especially important during these times. So we didn't want to overwhelm the classroom teachers because they have so much on their plate already with the real-time like online curriculum. And what we started to do is that we thought it was a chance to record our curriculum as modules and to give it to them, and they could disperse it to even more students right now as well. And then for the mentorship portion, we're hoping to start offering maybe sort of optional office hour type sessions. That way they don't have to come on, they don't have to feel forced, but that they know we're there to answer any mentorship questions and to chat even if they need to.
Oh, that's kind of cool. Great ideas. Allie, I'm gonna just, being a student in our department, I had to make sure we get a question to you. So this is really my question for you. Just wax poetic about why you think there's so few top studies on sexuality education and basically the issues of IPV and sexual violence more generally, dating violence, that sort of thing.
Yeah, so I think a lot of it comes down to the fact that sexuality education has been really thwarted by like political or religious groups. And so that's also affected how research is done in that area, which has really limited the scope at which it could help in IPV or more generally sexual violence prevention.
Right. I think we might have time for a couple of more questions. Asta, I don't want you to feel left out. I'll probably come back to somebody else, but somebody put a question about what are some of the implications for your research for, well, for lack of a better term, real life. Not that research isn't real life, but outside of the research context.
Yeah, that's a really great question. And that's part of the reason why I've really enjoyed working on this study is that the real implication is to have an intervention-based program in hospitals to address risky behaviors among adolescents, right? So we know that social workers are often, overworked and are burdened with other things. And so we're really hoping that child specialists in emergency departments can take on the role of facilitating these interventions and getting engagement with the youth to not only do injury prevention, but further, reduce alcohol use and aggression among these adolescents. So yeah, that's the goal. Great.
We have time for one more question. I would be remiss if I didn't ask our intrepid leader, the person behind this whole symposium, making it all work, is Jessica. Can you kind of just tell us a little bit about how the injury, the prevention work is in a primary care setting is different than, or why primary care? I mean, why, and then what are the differences, and are there? I mean, obviously an emergency department is different, but you're still talking to a physician, or are you?
Yeah, I think that's a great question. So I think primary care is a missed opportunity for a lot of violence prevention work. It's where a lot of adolescents and young adults are receiving care and really interacting with the healthcare system, but not getting maybe that extra level of prevention, intervention, and prevention work in order to prevent things like violence and substance misuse. I think what we found in this study is that a lot of the clinics were open to doing work like this. I don't think that we're talking about having the doctors perform the intervention, but rather behavioral clinical staff do it. But I think this is a missed opportunity that we're not doing more work in our healthcare settings in order to interact with our most high-risk youth.
Great, thank you. Well, we're really at the end of the time. I would like to keep going here. I'm learning a lot, and I appreciate all your presentations and your time today, and looking forward to seeing these papers in publication at some point in the future. So thank you for joining us on the symposium. Thank you, Jessica, for putting up this last slide. About, just to remind you that we're recording these. You can go see it at our website. And if you're not already a member of the Injury Prevention Center here at the University of Michigan, you can please join, go to our website and become a member. And there's all sorts of other information on our website, whether or not you're a member. So I would certainly welcome you to do that. Don't forget to do your evaluation survey. And thank you again for attending. And I appreciate the opportunity to be your moderator. I'm honored to do that. So thank you. Have a great day and happy holidays to everybody, and be safe. Bye.
Thank you.